Good morning everyone. So today's lecture is on trauma in the primary teeth. So the intended learning outcomes: at the end of the lecture you will know the management of dental injuries in the primary teeth. So the history of trauma is important as it provides information regarding the time of trauma, the place of trauma, how did the trauma occur, and any associated symptoms with the trauma. So the first is when did the trauma occur. So the time lapse between the time of injury and the treatment affects the prognosis. If the time lapse is a lot, then the prognosis will be poor. That is in the case of pulp exposures, displacement and avulsion injuries. Where did the trauma take place? Was it in a playground or in the class or in the home? Because if it is a playground, that is considered as a dirty place, while in the classroom or home it's comparatively cleaner. Then we have to consider giving the patient tetanus protocols or tetanus protections or medico-legal implications that needs to be considered. Then to retrieve the tooth or the fragment from the place of injury or not. So the next thing that we ask the patient is, how did the injury occur? So is it a accidental type or non-accidental? If it is accidental, then again medico-legal implications needs to be considered. Then the treatment elsewhere or the source of referral. So we need to ask the patient if there is any treatment that was done elsewhere, or has the patient been referred to from any other dentist or a doctor. In the case of reimplantation, we need to know if the patient has already been treated, how was the treatment, when was the treatment. All these questions needs to be asked to the patient. The history of previous trauma also indicates if needs to be asked if it is a repeated injury to the same tooth, then the prognosis will be poor. We need to even see if it's a child abuse type of case or if the patient is epileptic. The other associated symptoms related to caused because of the trauma is any loss of consciousness or amnesia or drowsiness or headache. Indicates it's not only the dental trauma that has occurred, it's also that is head injury may be involved. If the patient gives any history of spontaneous pain, then there might be a damage to the supporting structures. Reaction to any hot, cold, sweet or sour food indicates that is some amount of pulpal exposure or dentine exposure has happened. So in this case we generally have to seal the tooth structure or the fractured area with either GIC lining or calcium hydroxide lining. Any sensitivity to pressure on eating or chewing indicates an occlusal disturbance. Next, how do we assess or evaluate any soft tissue injuries? So clinical evaluation is done to see or assess the extent of injury or the damage, if the damage is minor type or a major type. Then we need to assess the type of damage. Is it a laceration, abrasion? Is it a complex type of injury? Is it a bite mark or avulse type of injury? In laceration type, we generally suture. Abrasion, we need to decontaminate the wound. In complex injuries, which needs to be treated under the general anesthesia, any avulsed injuries which is associated with loss of the tissue, that needs to be replaced or grafts need to be replaced. And we need to check for any bite wounds. So the bite wounds would indicate a child abuse. So how do we manage these soft tissue injuries? So we manage by debridement, hemostasis. Then any type of contaminated wound needs to how we manage. Then the primary closures and post-operative wound care. So in debridement, what do? We remove any dead tissue, any foreign body objects, followed by cleaning with scrub and saline or dilute betadine. Hemostasis is to avoid any excess loss of blood from the body by application of pressure packs, gel forms, bone bags. Any contaminated wound needs to be treated with antibiotics and tetanus toxide has to be given. Next is the primary closure is by suturing. Delayed primary closure is done in contamination or edema. Secondary closures are done in infected wounds. Then the post-operative wound care needs to be taken care of. So the hard tissue injuries, how do we assess? It's first by clinical evaluation, radiographic evaluation, and then vitality testing. So in clinical evaluation, clinically what we see in the patient, radiographic to assess what we clinically see, and to diagnose or come to a treatment plan, and then we do the vitality testing. Generally, vitality test may give a false reading if the patient is anxious or immediately after trauma. The tooth might be in a state of shock. So vitality testing is not done immediately after the trauma. If the root formation is incomplete, that again gives us false reading, and if the tooth has a crown or a splint, will again gives us a false reading. So moving on to the treatment of traumatic injuries to the primary dentition. So the first type of injury, that is injuries to the hard dental tissue and pulp. So the first one being the enamel fracture. So enamel fracture is any, as you can see in this picture, chipping of the incisal edge in 5-1 and 6-1 and even 5-2. So in this type of case, what we have to do, we have to smoothen the sharp edges and apply fluoride onto the surface. Can do slight recontouring of the incisal edges for aesthetics. Acid edge composite can also be utilized for small or large chips of enamel that and which gives a good aesthetic result. If there is a fracture of the enamel and dentine, then we need to, as you can see in this picture, fracture of the enamel and dentine, the next thing what is we do is radiographs. We need radiographs to confirm or come to a diagnosis if it is involving the enamel and dentine only or involving the pulp. If it is only involving the enamel and dentine, then we need to give a calcium hydroxide or glass ionomer lining, followed by composite restoration or the glass ionomer restoration. Crowns can also be given if a large tooth area is or tooth surface is missing. We can give crowns, that is preformed polycarboxylate or composite or aesthetic crowns can be placed, and the patient is scheduled or recalled every 6 months for monthly checkup. If the fracture fragment is involving the pulp, then as you can see here, involving the pulpal exposure, that means the treatment largely depends upon the patient cooperation. We need to take radiograph first to see if it is only involving the coronal part and not involving the radicular portion. So pulp capping, once we take a radiograph and there is no radicular involvement, then pulp capping is not indicated in primary teeth because there are high incidence of failure that can be seen in primary teeth. So the next treatment that is that can be done is pulpotomy or pulpectomy. Pulpectomy only if 2/3 of the root is still present. Then aesthetic and prosthetic replacement if the patient is uncooperative or there is a risk of damage to the permanent tooth bud. Moving on to the root fracture, as you can see in this picture, there is a 5-1 and 6-1. There is a horizontal line you can see, and the root extending, which is you can also make out in the radiograph. So If the fracture line is involving the apical third, it has the best prognosis because we just need to monitor the patient, and if the patient does not have any symptoms, we just monitor, and with time the apical portion of the root will resolve by itself. If the fracture line is in the middle third, which usually results in the tooth being mobile, and hence you need to extract. If the fracture line is running in the involving the gingival third, then it has a poor prognosis and it should be extracted. Moving on to the periodontal tissue injuries, there is a concussion or subluxation. The tooth should be left alone. Parents should be given instruction to feed the child on soft diet and maintain good oral hygiene. And as the periodontium heals, the pressure from the tongue will help in repositioning the tooth back to its position. If there is intrusive or intrusion injury, radiographs need to be taken. As you can see here, clinically the crown portion cannot be seen. This is the same patient. As you can see, the tooth has intruded, and this is after 6 to 12 months that you see that the tooth has erupted back into position. So radiographs we need to see, or we need to take a radiograph to see if the primary tooth is damaging the permanent tooth bud or not. If the tooth is impinging on the permanent tooth bud, we need to extract the primary teeth. But if it is not impinging, we need to wait and watch. It might be from 6 months to 12 months also. And if in the 6 to 12 months the tooth shows no signs of any movement, then we can suspect that ankylosis has occurred, and we need to then perform extraction. Any type of luxation, that is lateral luxation injury, so we need to see if it is palatally luxated, buccal luxated, or severe displacement. So if it is palatally luxated, we generally need to reposition the tooth manually and splint it, and if the tooth shows no signs of improvement over 2 to 4 weeks, we need to extract the tooth. If there is buccal displacement, then the tip of the root will damage the permanent tooth bud, especially if calcification of the permanent tooth bud has not taken place. Then the most and the critical treatment plan that we have to do is extraction of the primary tooth. Any extrusion type of injury, if it is depending upon if it is slight extrusion or severe extrusion. As you can see here in the picture, there is slight amount of extrusion injury, and if it is slight, we generally leave it intact and we need to just monitor the patient periodically. But if the extrusion is severe and the tooth is almost lost its vitality, then it needs to be extracted. Then if the tooth shows marked mobility, then again the tooth needs to be extracted. X articulation type of injury, in all the cases it is possible. The most important thing is to locate the tooth. If it is not there in the oral cavity or in the socket, we need to locate the tooth. So to locate the tooth, we need to take chest x-rays to rule out the presence of tooth in the airway. And most of the clinicians do not consider of placing back the tooth or replanting the tooth, because that might damage the permanent tooth bud, or the primary tooth may get ankylosed and hence cause difficulty in normal exfoliation, and that will prevent the eruption of the permanent tooth bud, which again the lost tooth can be replaced with a prosthesis, which can be a choice for patients. So why do we need to extract the permanent primary tooth bud if it is hindering or causing any or impinging on the permanent tooth bud? Because we need to keep in mind that there is a close relationship between the apex of the root of the primary tooth and that of the permanent tooth germ. So tooth malformations can occur, like any impacted tooth, eruption disturbances. So these are some of the sequelae of trauma to the primary teeth that we see. Either it is a reversible pulpitis or irreversible pulpitis that we can see. Any infection to the periodontal ligaments can occur, or pulpal necrosis. Sometimes we can even see pulp canal obliteration, inflammatory resorption, which may be external or internal type. Ankylosis or replacement resorption can be seen. Any crown discoloration, as you can see here, crown discoloration, injuries to the developing permanent dentition. And this injuries to the permanent dentition may be because of the, as I've already discussed, that the apex of the primary tooth can impinge on the permanent tooth or tooth germ. So the crown discoloration in the primary teeth is most common complication that we see in the luxation type of injuries, and this discoloration may fade and the tooth might regain its original color. If the tooth is discolored but asymptomatic, then there is no need of any treatment. But if it is associated with any pulpal necrosis, then pulpal treatment needs to be done. So a pulpectomy needs to be done in such type of teeth. So injuries to the developing permanent dentition can be like Turner's hypoplasia. So as we all know, that Turner's hypoplasia is what? There is single tooth discoloration. As we can see here, this is due to the trauma to the permanent tooth bud or tooth germ from the primary tooth. Or yellow or white or yellow brown discoloration of the enamel, crown dilaceration, odontum-like malformation, we can see partial or complete arrest of root formation, sequestration of the permanent tooth germs, or the most common is disturbance in eruption or delayed or ectopic tooth eruption. So moving on to the IADT guidelines. So what is IADT? IADT is International Association of Dental Traumatology. So according to the guidelines, we have the clinical findings, the radiographic findings, and the treatment that we can do for each type of fracture or injury to the primary tooth. So if it is a enamel fracture, the clinical finding that we see, it's just involving the enamel. Radiographic findings, no radiographic abnormalities that can be seen. So the treatment option will be smooth the sharp edges. But if the fracture is of enamel and dentine fracture, as we can see here in this picture, that is involving enamel and dentine and not the pulp, then no radiographic abnormalities will be seen. But what we can do is seal the fractured area with a glass ionomer to prevent any micro leakage. And in case if a large tooth area is lost or the tooth structure is lost, we need to restore with a composite restoration. If the crown fracture is with exposed pulp, that means fracture involving enamel, dentine and pulp is exposed, we need to take a radiograph to rule out the stage of the root development to determine the exposure. Then we have to preserve the pulp vitality by partial pulpotomy. So calcium hydroxide can be placed on the tooth surface, after which it can be covered with a glass ionomer and restoring it with a composite, or depending upon the child's maturity, if the child is cooperating, we can do the treatment, that is partial pulpotomy, and if the child is not cooperating, then extraction is the best alternative that we can do. If there is a crown root fracture, depending where the fracture line is running, if the fracture involves the enamel and dentine and the root fracture, the pulp, if it is not exposed, or if the tooth may be loose or attached to any fragment of the tooth, then the treatment, we need to take a radiograph to check the fracture extent. The treatment that we can do is the fragment removal if the fracture involves only the part of the root and the stable fragment is large enough to allow the coronal restoration, or extraction in all the other instances. Moving on to the root fracture, if the root fracture, the coronal fragment may be mobile and may be displaced, then we need to take a IOP or radiograph to locate it's a mid-root fracture or apical root fracture. If the coronal fragment is not displaced, then no treatment is required, and if the coronal fragment is displaced, and repositioning and splinting should not be considered, and it's always better to extract. And if it is only the apical fragment, apical third which is fractured, then it should be left to be resorbed. Then now moving on to the concussion type of injury, if the tooth is tender to touch and it has normal mobility and no sulcular bleeding, and radiographic findings we see that is no radiographic abnormalities, no normal periodontal space, then no treatment is needed. In such case, you need to observe the patient, recall the patient every 6 to 8 weeks and check again. Next is the subluxation type of injury, in which the tooth has increased mobility but it's not displaced out of the socket. Bleeding will be there from the gingival crevice, can be noted. In this, the radiographic finding that we see is the normal periodontal space, and the treatment that we can do is no treatment is required, only observation, brushing with a soft toothbrush, use of chlorhexidine which is 0.12% topically in the affected area, with cotton swabs twice a day for 1 week. Next is intrusive luxation. If the tooth is displaced palatally or lingually or labially, and it will be immobile, so in this case we need to take a radiograph to see if it is impinging on the position of the tooth, and the treatment is spontaneous repositioning of the tooth has to be done. And if it is if the apex is displaced into the developing tooth gum, then we need to extract. Then in avulsion type of injury, that is the tooth is completely out of the socket, then radiographs has to be taken to ensure if the tooth is missing, is not intruded, and it is not recommended for to replant the avulsed primary teeth. So in this picture what you can see, which is of a skull with the primary and the permanent dentition, as you can see all the primary teeth and the permanent tooth germ or tooth which is underlying. So in 6-1, as you can see, there is some amount of trauma that has intrusive injury that has occurred to the 6-1, and that tooth has affected the permanent tooth. That is in 2-1, you can see there is brownish, yellowish brown discoloration of the tooth compared to 1-1, which is white. So this indicates that the 6-1 had trauma and it was of intrusive type, and the apex of the primary teeth has damaged the permanent tooth, and that in turn has caused discoloration of the permanent tooth. Thank you.